isometric is where I stand at a wall and push forever with my arm against the wall and don't move anywhere. Obviously it creates more cramping in my arm. ICP and eccentric movements often in bruxism is where the closure occurs. So when we move in a lateral-obtrusive way, again our 236, we know as it moves out that those cusps are going to pass by each other. Essentially, we want a mountain to move through a valley. And if we basically put our cusps back in here, our mesiopalatal cusp, and our distal buccal cusp, and their centric stops, we want to see where the lateral obtrusive motion is. And ultimately, on a lower six, the lateral obtrusive motion is direct lingual. On an upper molar, it's direct buccal. And that's the bull rule. Buccal upper, lingual lower is the straight pathway. As simple as that sounds, the number of times that we see issues with our patients because it was done with a stock library tooth out of a scanner and then CAD-CAMmed or whatever, where these grooves are in the wrong place and we don't get a straight buccal or a straight lingual pathway is ridiculous. So ultimately, when I'm sitting chair side, it doesn't matter whether I'm equilibrating, whether I am doing a filling, whether I'm doing an onlay, an inlay, or a crown. I will always keep in mind buccal upper, lingual lower, and I will always do that when I'm adjusting my splints. I make sure that I understand the general pathway of a six is going to be lingual on the lower, buccal on the upper. That's the first thing that I'm going to clear. It gets even more exciting when you look at the medial-obtrusive pathways and you start to appreciate how intricate our teeth are and how beautiful they are with respect to how they move against each other without interfering. So in medial occlusion, if we put in the same cusps, and we think, where is that medial occlusive pathway going to be? Well, on the upper tooth, it's going to be just mesial to the mesiopalatal cusp, and it's going to clear there. But on the lower, look at that, isn't that cool? It just missed the distal buccal cusp and the distal cusp in that pathway. But what happens if our orthodontist friends make the tooth a little too rotated? Obviously, it may not clear. Obviously, there may be an interference. And again, in everything that I'm doing chairside, I'm going to look at these pathways and in my head memorize them to make sure they don't interfere. Again, when I'm adjusting my splints, I'm going to be clearing these pathways because these are where the normal interferences are. Now, we're only talking about 2, 3, 6, but we can take in our minds and we can understand that as you go more posterior or more anterior, the angulations just change a little bit, but basically it's the same pathway. So we get a medial-obtrusive interference because of many different reasons. One of the reasons could be like this tooth, that it's tipped and over-erupted. It's standard in North America a lot in orthodontic offices not to bracket lower sevens because they're not in yet when the case is finished. So I deal with this on a constant basis where the tooth was never actually touched by a bracket. It was not even erupted or partially erupted when the braces came off, and now we have an interference. What is the other reason that you can get a medial-obtrusive interference? If you think in your mind, it can be because something changed. And what can change? As people age, they get wear. And as they get wear, we're going to get more medial-obtrusive interferences. Where is that wear going to be? For a medial-obtrusive interference, this is tooth 4-7. That mandible's moving to the left. We're probably going to look at the patient's left side and probably towards the anterior, where that guidance may be going down. But what are the consequences of a medial-obtrusive interference? By the way, there's the wear right here. So maybe they used to have a little bit more cusp there. Maybe that used to disclude, but as people get older, their teeth may hit in ways that we don't want them to. So what are the 6 consequences of a medial-obtrusive interference? Well, the first, of course, can be pain. Pain in the tooth, pain in the joint, pain in the muscles. We can also get the tooth migrating. It doesn't like to do that, so it might move. And if it's moving, it may get fractus, where all of a sudden you put your finger on the tooth. Usually I run my finger along the buccal of the upper, and I have the patient move, and all of a sudden the tooth is dancing. That's not good. It can fracture. You can get periodontal load, and you can have distraction of that condyle. As the mandible goes out to the left, it's a speed bump. And it's the way I explain it to my patients. A speed bump, in Spanish it's tope, and I don't know what it is in every other language, but ultimately as a car goes along and it's trying to slow you down, it goes like that. And Medial intrusive interference as the mandible goes out causes the mandible to go like this. And as it does that, it takes the condyle and distracts it. And that's not a good thing. So again, with the medial intrusive interference, always look to the opposite side and look to see what is there, because that guidance is probably not going right, or it was never considered, or you have a tooth that's tipped. There's two more pathways we have to discuss, of course. And the first is going to be protrusive. So if you have nice straight sixes, properly designed, proper place, the pathway protrusively on the upper six is going to be straight towards the mesial. On the lower, it's straight towards the distal. The big cusp, the mountain, is going to go through the valley and it's going to clear each other. But again, if the teeth are rotated, it may not. From a prosthodontic standpoint, and believe me, I have proved this to myself way too many times, probably one of the most important pathways is lateral protrusive. So again, moving your mandible forward and to the side. It sounds simple, but a common place for the mandible to go in bruxing. And what happens when you go lateral protrusively is at the level of the molar, you tend to go right over the mesiobuccal cusp, and on the upper, and on the lower, right over the distal lingual cusp. I'm going to show you in a second, but think in your mind of teeth that you've seen broken, and now start to speculate on what might have broken that over time. Clearly the tooth probably had a large restoration in it, but why would it often be the distal lingual cusp that breaks on a lower six? Maybe this. So again, in a sequential way, we know that the 6 is discluded by the 5 discluded by the 4 in lateral protrusion in an ideal world. Again, the basics of sequential guidance. So I want you to look at this. So here, as we stare at these teeth, we'll take this 4-6 here. We look here that there is the lateral protrusive pathway as the mandible comes out to the right. This is lateral protrusion. That cusp is completely blown out. Here is our medial protrusive pathway and our protrusive pathway. So you start to stare at this and you start to understand, why might this have happened? Well, clearly there was probably an occlusal amalgam that became a bigger amalgam, it became a bigger amalgam. But also we can look to the anterior for wear. In the lateral protrusive pathway here, we're going to look at these teeth. Perhaps they're worn down, making that pathway get more. In the medial protrusive pathway, we're going to look to the opposite side. And in lateral protrusion, again, often happening in bruxing, we're going to follow those pathways. And the more that I looked at my own patients, once I understood this, the more I started to see reasons for the actual problems in the posterior teeth that were not reflected in any other way than by the fact the patient's getting older and wearing new teeth. And what wears the teeth the most? As I showed you from Lundin and Gibbsworth, it's going to be the bruxing force. A little closer up of that, but note the damage that's occurred, and I don't think it's a coincidence. I think it has to do with what we see. This is again just a reminder of what each tooth does in the arch. So in the upper arch, in the green, we can call these controlling teeth. The two canines are controlling plus guiding, so controls. Remember, we don't want guidance on the upper incisors. Premolars are in yellow, support and also control, lateral protrusion and retrusion. In the molar region, red is the support during growth and development. Now in the lower arch, it's a little different because you'll note that we've included the 4s in this area, support and control. And the molar region is red. So always keep in mind what the function of these teeth are, because when we look at lower 4s and we talk about building and making sure we have proper design for retrusive guidance, our 4s are considered to be controlling in this case. All my pictures are from last year. I guess that means I spent a lot of time here. It's weird. So the anterior determinants of occlusion. Why does this happen? We look at this with people and we see it all the time. This guy has many things going on. Super nice guy. He's actually the guy that fixes my furnace and my air conditioner. But he spends a lot of time on his front teeth. He destroys his front teeth. Over-eruption of these teeth, 2-step terminal plane. Nice gold work in the back, because I told him nothing else would last. It lasted, but his teeth didn't do so well. In North America, the typical restored anterior tooth is this, and the lingual design is this. It's kind of like if you take two models and put them together, how much can you fit in there? That's pretty much the design. That's the science. This is actually now a very good friend of mine that I reconstructed, but he had these crowns done 6 years previously, and at that time didn't have a diastema. So when we talk about interferences creating migration, this is an example of that. So we know that it's very nice to make the outer teeth look beautiful, but the inside, the lingual, and the design of the lingual is one of the most critical things. So Harvey Stallard in the 1930s, he came up with canine guidance, anterior guidance as a way to help solve his problems where they had a bilateral balance on the dentures, and now we're trying to fix teeth. Boy, that's hard to do on the teeth, as I said. So he came up with cuspid guidance, the theory of it, which of course took over and dominated so much of our thoughts. But all of us that are VSED trained have in the back of our minds this little thought going, okay, but when do we use cuspid guidance? How much do we use? Can we use too much of it? Bill McHorris, who's a very interesting man that I got to know, he was a really tough educator. Ellen and I are tough. He was tough. But he was heart of gold kind of guy. Back in 1989, Bill McHorris, who I know Professor Slavichek knew, came up with this research here, where he said the anteriors guard the posteriors in flexing. Well, that's true until the anteriors wear down. Friction produces wear on the anteriors. And again, most friction occurs in an excursive motion, side to side, because of course that's more friction. When you think about wear, it doesn't happen instantly, it happens gradually. So first you might have one point of contact, but as that contact wears, you get more points of contact. And as it wears more, you get more and more and more points of contact. So wear is exponential because the more of a frictional surface together, the more the friction will wear that surface. Which is why you see as people wear, as they get older, all of a sudden it goes exponential. He stated that friction decreased with a cuspid occlusive angle equal to the condylar exclusive angle, a 1-to-1 ratio. So in his research, he had it at 1-to-1. We'll talk about what we consider now. We know that the anterior disclusion significantly reduces the electrical activity of the masseter and the pterygoid. And that was sort of the research that basically precipitated a lot of the thought processes of Pankey, Dawson, Spear, and Coyce, where anterior guidance is everything because it shuts down the masseter and pterygoid muscles. And to a certain extent, that's true. But further and better research, I think, long-term, came up with the fact that sometimes you can have too much of a good thing, and maybe it's a little more complicated. But the anterior teeth disclusion does provide a class 3 lever in function. You've all seen this slide, but it's one of my favorites from way, way back. And basically it says, is there an actual relationship between anterior guidance and condylar inclination? Professor Slavichek always said to us that I just watch nature, and I study nature, and I see what nature does. Well, here's a study of nature. Here we have an infant with no teeth, and we have a sagittal condylar inclination of 0. Basically, what is the function of that mandible? It's to suckle, it's to nurse. So the mandible goes AP, 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 and that's all it does. So it doesn't mean anything, but as soon as the teeth start to hit, usually around age 7, 8, in that area, sometimes 6, we start to develop an eminence, and we start to get some sagittal condylar inclination, maturing to eventually with all the teeth discluding in there. So do the teeth create this? Certainly they have an effect. So if growth and development creates part of our joint, it's logical to think backwards and say there must be a relationship between the anterior teeth and condylar pathways. So essentially we know that we try to create 10 degrees more inclination with our incisors to our sagittal condylar inclination. Where does that come from? By the way, the 0 degrees for cuspids, Professor Sato often quotes. This makes sense to me because if you have a condyle here and you have a cuspid here, and the mandible is moving like this, where are you going to get the least friction? Because if the condyle is moving, say, at 44 degrees, and the cuspid set at 44 degrees, will there be much friction? No, because it just all goes in a diagonal. Same on the other side. If you increase that from 44 to 54 to 64, obviously you're going to create more friction and you're going to create problems. We know, again in review, that F1 and F2 are the points of contact. F1 is your center of stop. F2 is the maximum protrusive position where the teeth touch. We know that if we draw this tangent, that gives us our incisal guidance inclination. And we can also, in our software, see that that can be determined as S, that tangent. When we trace our cephs, especially because we don't really trace the incisor, what we use is a stock tooth. We really don't get the incisal guidance inclination. We get the inclination of the tooth, the axis of the tooth, to whatever reference plane we want. But what's functionally important to us, again, is the lingual. It's the F1, the F2, and that pathway. There's another factor with a tooth that some of us have heard before, and that's something called a column angle. Column angle is the angulation of the root and the crown. So some people it's like this, the crown and the root are kind of parallel. Some people it's like this, and some people it's like crazy, where it's like a big angle. So if you just take the root inclination and use that in your definitions, tracing cephs, etc., and don't take into account actually studying here, you can end up with problems. The problems being that you're not actually getting the true incisal guidance information. So Professor Slavicsek, one of the beautiful things about being here was he had almost an unlimited number of patients where he did full records on at the university, which is why he comes up with N values of like 1,200 people. So he did his anterior lingual concavity study, and basically, here's the publication. Again, we've all done this, we've all sectioned the teeth, and we've all looked at the actual inclinations here. But when he did that, he came up with, out of the 1,200 patients, this beautiful bell curve, which is very steep, where you look at here, for example, here's your sagittal cone inclination on the y-axis. This axis here, this axis is the incisal guidance inclination. So say we take a sagittal cone inclination of 40, we come across here, drop down to 50, that's about 10 degrees. So basically, through all those people, he came up with the average in that population, the mean of 10 degrees. Hence the reason that we look to go roughly 10 degrees steeper with our incisal guidance inclination to the sagittal cone inclination. So, Lundin and Gibbs, going back to them, what were their rules for anterior guidance? And here's theirs. Their conclusions were, we avoid the anteriors in mastication. Well, we know that. We don't clunk on our teeth, hopefully, unless we over-restore them with porcelain or zirconia or something, and we don't take the envelope of function into account. But we try to avoid them. The functional interferences. That means the mandible, three-dimensionally moving through space, has to come to a landing spot. And the landing spot, as you close into ICP, is going to be dictated by the inclination of the actual anteriors, particularly the cuspids. Canines and laterals touch lightly during mastication. They don't touch heavily. The orientation contacts occur during rapid sequential chewing. When Professor Slavicsek taught us with our dentures to actually create cuspid guidance, which really wasn't cuspid guidance, it was a control, it looked kind of funny because we all thought you put it on an articulator and you go excursively on your articulator, of course the denture is going to fall out. But that wasn't the logic. The logic was is the mandible is in a closing pattern, the cuspids are going to dictate where it actually lands. In other words, if you made it shallower, the mandible could go on a wider pathway, but they showed, Gauss for initially, as you steepen that cuspid, the lingual of the cuspid, the mandible will close more vertically into that position, hence the research that corrected it. And that's what I just said. So Ken Tamaki was actually in my master's class. He's a cool guy, but this was just a little bit before. But this research, these two research papers, have affected my thought process so much prosthodontically. Prior to that, and I think still in North America for sure, nobody gets this, and yet it's excellent research. I think he did most of it on his grad students. I'm glad I wasn't one of his grad students. But ultimately, at Kanagawa with Professor Sato, he did the first study where he did teeth that are involved in lateral guidance versus the amount of muscles. And the second was the steepness of the guidance and the effect on the muscles of the joints. So in other words, you got two parallel things here. You're looking at how much muscle does it take with how steep a guidance, and same thing, what's the effect on the muscles and the joints as you steepen that guidance. So, the first study here is what happens. He's going to take a nice dentition, he's going to study this with EMG, he also did ontological. And what he's going to do is artificially create guidance on the threes. So that will be the dominant guidance. Then he's going to do 3, 4, then he's going to add 3, 4, 5, 3, 4, 5, 6, 3, 4, 5, 7. This is all in the same patient. So now you can see what is the differential effect per patient on each of these things. It's a very cool study because what it basically showed is this, that the muscular effort, this is EMG studies, when you have a 3, 4, or even the 3, 4, and 5 touching, is actually relatively low compared to as soon as a molar contacts. So in my world, how does this affect everything I do? Is number one, if I'm doing a quasi-group functional occlusion, I do not have my molars contacting. If I'm adjusting my splint, I do not have the molars contacting in a just simple puppet splint. If I'm doing a restoration, just a simple filling, I make sure that my lateral obtrusive and my medial obtrusive pathways are clear. It's a simple 2-second extra exercise to do that. And that way, what I'm trying to create is not to have that extra muscle activity. Now the second study was even pretty cool, and that's where he took, and he did cuspids, and he took the incisal guidance inclination equal to the sagittal collar inclination, or horizontal collar inclination. Then he increased it by 5 degrees, 10 degrees, and 50 degrees. So this is the whole part of so much dentistry now, and what is taught by Dawson, Spivak, Kois, Henke, about creating anterior guidance. It's a good thing, because it gets you out of everything, you just make it. Well, anybody that's practiced for longer than a week in dentistry realizes you can't do that all the time. And if you do it, you're going to have to do this a lot. You're going to create essentially a gorilla, but you're also going to create possibly some pathology. It looks like a gorilla, like with little overlays. So what happened as you increased the steepness of the incisal guidance? Increase in hyperactivity in the masticatori muscle. Lateral displacement of the mandible. What does that mean? You're going to cause almost a fencing of the mandible so it can't get out. It's trying to go excursionally, but it can't. So something's got to happen. It's going to try to move. Maybe instead it's not going to go just laterally, it's going to go 3-dimensionally and start rotating backwards to try to clear from that cuspid. And backwards in the joint is not a good thing. It causes compression. And that would be the backwards and upwards movement of the condo on the same side. Also, you create more digastric muscle activity. Do we remember digastric muscles and what they do? They are primarily responsible for opening. And if you have more tension through here in your digastric muscles, it's because you probably have to rotate open much further. A class 2 division 2, for example, is going to have to go open more to go protrusively than somebody like me who's class 3 with an open bite. I mean, it's probably not going to be a big deal for me. I don't even know if I have digastric muscles, so I do, but I need so much for that. So, what's interesting when you look back at the research is many people have talked about this physiologic relationship between incisal guidance and posterior guidance. But basically the difference we've ascertained to be about 10. One of the best ways to prosthodontically mess up your patients, and I mean this sincerely, is to make the front teeth too steep and not take into account this, the intercorneal opening angle. If you create a lack of room there, you're going to do what I just said. You're going to create rotation before the mandible goes protrusively. And if that happens, you're going to engage more muscles, and the muscles are going to create more problems. For example, in this case, what I just said, the digastric muscles have to be applied because ultimately this patient can't go protrusively too easily until they open. We see this in our condylogram. We see it when we're plotting rotation versus translation curves. And we see a nice 45 degrees ideally, but all of a sudden you'll see just rotation, 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 and no translation. Summary. If we call it the VSIP concept, I sort of don't like using the words philosophy and concept because I've used this for so long, I just feel it's right. So I tend to talk about how can we study nature as Professor Slavichek did. That's not a concept, that's just reality. So the reality here is we can use recorded movements, as we know with condylography, to define our anterior tooth guidance because we'll know our sagittal collar inclination. Summary would be the upper incisors are slightly unloaded, as I said. We don't use the central incisors as excluding structures, they're controls. They are used in speech. Typically your S sounds, your lower incisor, upper incisor, most people, 90%, when they make an S sound, will protrude their mandible and lightly touch their incisors. If you've ever done a denture where you make the teeth a little too long, and you ask somebody to hit an S sound, and they go, and they tip the denture, it's because the teeth are not in the right place. If you've ever made a denture where somebody whistles a little bit, you probably have them too short with the S sound, because it's a protrusive and incisal thing. If you're very critical with your models, and you look very carefully, Sheree come back, and I forget what year, but she had studied something called a different type of wear class. Most people on the lower incisor, you see the bevel from bruxing, which is kind of like this. If you look at the top of that, often you'll see a little flat area. So you have bevel and then flat. That flat comes from the S sound, because S is a completely vertical motion like that. When I read that and I started to look at it, I see it. So this is something we must respect in function, because if we make the teeth too long or too short, we can create problems. And yes, some people adapt, but if it's in porcelain, it's very hard to adapt. This is a controversial statement to me. Upper lateral surgeons may be used in eccentric lateral intrusive working guidance. Not in my father, because twice he has broken his crown on tooth 1, 2, because he bruxes protrusively. When you have a lateral incisor in a typical class 1 occlusion, what hits when you go lateral protrusively? It's the lower cuspid. The lower cuspid, very strong tooth with a point, will catch the distal incisal of a lateral incisor every single time. So twice he's broken it. He wears his night guard when he sleeps at night, but my dad's 94, so he sleeps like 6 times a day. And when he's grinding, this is when it happens. I last Saturday fixed it again. So with that, so always bear in mind, lateral protrusion, lower cuspid hitting distal incisal incisors, whether it's composite, whether it's porcelain, it does not matter. I've now got, literally on my dad, he initially had a 3/4 lingual veneer. He's a dentist done in dental school, which he broke off. He had my first porcelain crown, which he broke off. The second porcelain crown, which he broke, which I fixed just with composite because I was in a hurry last 2 weeks. So please remember this. Upper front teeth are never steeper than 60 degrees as a rule, and the upper canine is never steeper than 50. And again, that's probably more because we're trying to create a lack of friction with respect to the joint lines. And again, allow freedom. The upper canine is dominant in guidance structure, laterally protrusive. We know that sequential guidance with canine dominance, that means at the very end, as long as we can create it. Protrusion, the movement of the lower arch is controlled in the distal fossa of the upper canine. We don't try, especially in our reconstructions, in our ortho if we can, to have the incisors being the protrusive guidance mechanism. Very quickly we'll go through this, the axis orbital plane, Frankfurt, etc., just as definitions. So we know that axis orbital plane is orbitally to the hinge axis. We can only calculate that by finding the hinge axis. We know that Frankfurt plane, it's on average about 7 degrees different, but again, it's orbitally to the top of the external auditory meatus. When we do our anatomic facebow, arbitrary facebow, we are getting which plane? Frankfurt plane. When we do our hinge axis, we're getting, obviously, axis orbital plane, which is more accurate, obviously. Eccentric versus eccentric motion. So eccentric means going from in to out, more friction, more challenge. Incentric is in chewing mastication, for example, where we go down and back in, and more vertical force, where we're loading the teeth more axially, which is better for the teeth. The occlusal plane angle, by our definition, is the distal buccal cusp of the lower 6 to the incisal edge. There are many different occlusal planes in many people's occlusions, but our treatment planning angle is going to be this one right here. Sagittal condylar inclination, we know, we find it in condylography, and that's going to be axis orbital plane and the motion and an X, Z pathway, like so. That anguage. The Bennett, or the TCI movement, is measured using condylography, and again, it's the angulation here from the red, medial intrusion motion here, to perpendicular. Our cusp inclination, which is extremely important when we're designing occlusions prosthodontically,